Hi, everybody. Welcome back to Collaborative Corner, the podcast, where we bring you exciting audio tidbits to entertain you while you're taking a bath, or maybe when you're riding a bike, or when you're sitting in a CE class. So hopefully you can get a little bit of that. So before we start, I've got a guest pretty excited to have here today, but always kind of like to think about what's kind of going on in and around us, what's been approved, what's not been approved. And, we were kind of getting a little excited about the fact that we had two new dry eye medications that looked like they were going to get approved this year. One of them obviously already did. That's a Coumadin, which we've talked about before. That's a Trip M8. And if that doesn't, get you a little chilly, a little cool, a little evaporative thoughts there, then you don't know what a Trip M8 is. But we just found out this week that Aldera's products for COLLAB did not get their NDA. It was rejected by the FDA, which is kind of a pushback, I guess. AbbVie, which was ready to kind of market it and take over from there, was pretty excited about that. So they got a complete response letter from the FDA, which basically said they had some major deficiencies in their trials. So I know that Aldera is meeting with the FDA coming up. So we'll see. That was the RASP inhibitor. That's that aldehyde specific protein, which kind of works as an anti-inflammatory. So that's kind of cool. But the other thing that we just found out is that 10 Point, which is old Visus, they just submitted their data for NDA, for a new drug application, and that is for Brimcol, which is brimonidine and carbachol. 10 Point was Visus, and I know Qlosi is coming to market as we speak, and we also know Lens is ready to come to market, but we'll see what Brimcol does. So they just went to the committee on their presbyopia medication. So that's a couple things kind of going on. Throw a little tidbits out there. But I want to bring in our guest for a quick chat, a little communication. You probably know him very well. Why? Because he's everywhere. He's Dr. Walt Whitley. He's an OD. He's an MBA. He's an FFFO. He's everybody from Virginia Eye Consultants. Walt, thanks for coming in, buddy.
Hey, thanks so much for having me, Mark.
Yeah, my brother. A lot of people, this is an audio, so this isn't a visual, but a lot of people actually mistake Walt and I. I'll be walking down and people are like, Walt, and I'll be like, no, it's Mark. And it's like, whatever, Walt. Does that happen to you too?
It does. It does. I get a little tired of being called Mark every once in a while, but I just go with it.
Yeah, I know. It's like, dude, I've got hair. He doesn't. So Walt, I brought you on because I wanted to talk to you a little bit about something that I think you have a lot of experience in. And that's literally, how we communicate with patients. It's interesting because, when new products come out and let's use Xdemvy as an example, lotilaner, right? A new way of talking to patients about, things that kind of make you go, "Ugh," gross you out a little bit. I think it makes us step back and realize how we talk to patients. Just as a little amuse-bouche, how do you describe, or how do you tell patients that you want to prescribe a anti-parasitic for their eyes? How do you broach that?
I think the biggest thing is be just upfront with the patient, and it is what it is. And I tell them, hey, this is what I'm seeing on your eyes right now. You have bacteria, you have mites on your eyes. The good news is we can do something about it. Asking them, some of the symptoms, because they're not going to know what I'm talking about. But if I say, hey, do your eyelids ever itch along the lashes? They say yes. I said, well, that's exactly what we're trying to treat, is the mites and the bacteria that's on your eyelid. And then so first, so they can relate the symptoms to what's causing it, but then for the education, showing them. So if you have a video, a camera, just go, hey, this is what you have, and this is what we're going to do. Good news is we have treatments that we can offer for you right now.
But see, I've kind of felt like I used to use photo documentation to prove my point to patients, but I've kind of gone along the way of asking patients, and I almost kind of feel like, when we started talking about communication, I feel like, there's that whole thing about listening, and I'm not a good listener. I'm not an active listener. I talk
What did you
over.
say?
Yeah, I'm sorry. What do you say? I'm not listening well. I talk over people. And so I try to dominate the conversation, but what I will do is I will ask patients almost like permissibility. Like, would you like to see what I'm talking about? Would you like a brochure? And it's like, yes, then I'm gonna give it to them, as opposed to basically saying, let me show you. Because I think some patients don't always like that.
Yeah. Whenever we're talking to patients, no matter whether it's mites or whatever, it's always, what the condition is, why they have it, what we and they need to do about it, and what happens if we don't treat it. How does it impact them? Because if like, well, it's not bothering you now. Let's say the asymptomatic patient, because we know those are the hard ones, and say, hey, this is what's going on. Good thing you're not symptomatic yet, but this is why I'm prescribing this treatment for you, and this is when I'm going to see you again. But it has to be repetitive because, just like you and me, since we don't listen, we hear it once, we're not even going to retain that. So we have to hear it a couple times from the doctor to the staff, the follow up, sending them whatever education materials, whatever forms that you have that the patient can read more about their condition, whatever it is. That's so important and reinforcing.
It's interesting because, well, you and I have a little bit of a similar background. We both worked in cataract refractive surgery centers. We both have worked in and around, pre and post-operative patients. And I find often I'm reverting back to my refractive my refractive post-operative voice. And one of the things just listening to you now is I feel patients want to hear what is needed, and they want to know from a definitive, using your clinical acumen, tell me what I need to know, or better yet, tell me how well I'm doing. And I feel when you communicate with patients, you need to come at it from the perspective of, you know, this is what we need to do. Right? This is how we're going to manage this. And this is how we're going to prevent something from happening. And did you feel that, like, when you go in and give patients multiple options, that muddies the water as opposed to just basically saying, look, this is what we're going to do?
Yeah, I mean it's great to have options, but it does sure make your exam a lot longer having those options. But that's where our clinical experience comes in, and whether you're listening to this podcast, we at a CE meeting, at whatever meeting is, or exhibit hall, just talk to our colleagues. Why do they go to these type of medications? What are their go-to options? And I know you have your go-to options when it comes to dry eye, when it comes to IOLs, when it comes to glaucoma. We have options, but patients want to know, what do they need. They want our professional advice on what they need to do to address their condition.
I know that I keep harkening back, and I know we're talking communication, but it's so hard for me not to think of walking into a room and basically looking at somebody's visual acuity and telling them how well they're doing, as opposed to kind of just looking at the numbers. And a perfect example is, I always check both eyes. I do binocular before I do anything else. And then I say, oh, now let's see which eye's doing a little better. And then it's like, wow, you're doing amazing. It's like, do you think so? And I oftentimes will have texts come in and say, oh, you're only 20/25. Or, oh, that's disappointing. That left eye is not quite as sharp. It's like, dude, we're not pirates. We walk around with both of our eyes open, which always kind of brings me back to, again, when we're communicating to patients, we're communicating from the standpoint of we know more than they do. We have what's in their best interest, and coming at it from that standpoint of confidence.
You mentioned cataracts earlier, and sometimes people are like, "Oh, I give patients choices. Here's 5 cataract surgeons." They want to know who you want to go to. They
Right.
want to know who you want to treat their eyes, and so just making whatever you recommendation or prescription you feel is best is so important.
So one of the things that I also feel helps us with communicating is when you basically repeat back, what they say to you, so that you know what they're saying, and then you also can kind of do the same thing. So we're on the same page. So you're going to be using this drops and just kind of like leave it at the same for them to answer it. I feel that helps to kind of solidify that communication.
So what I hear you saying, Mark, is when you have that patient listen, then you communicate it back. I mean, that's reflective listening. I mean, that's essentially what we're getting to is so the patient knows exactly that we heard their complaints, we heard what's affecting them, but then going with that and making that recommendation.
I'm sorry, I wasn't listening well, but I think what you said was kind of the same thing I said. Do you ever, so something else too, I feel that helps, especially when you're communicating with patients. Obviously, the look them in the eye and, just kind of, make them feel like they're the most important person in the world. I try to do these things in my marriage and I fail and stuff, but one of the things that I've found too is asking patients, do you want a family member or do you want somebody else to come in here to you know to hear what I have to say. And I always kind of feel like having another ear, having another voice there helps what I have to say to patients resonate a little bit more.
Even before getting into that, because that helps. That way, because we don't remember everything that we hear when we're in an examination. But that first impression, right? We hear about you never get a second chance to make a bad first impression. So we go in with a new patient, and yes, we want to get to our EMR, we want to look at their case. No, we need to take a step, look them in the eye, greet them, introduce yourself, get some kind of dialogue with them so they're buying into you and understanding that, hey, you're there for them. Then go, give me a moment. I'm going to take a look at your chart because, in this EMR world, we're so used to going straight to the EMR, forgetting about that person in front of us, and it impersonalizes the whole interaction. And so to start with the communication, it's that first impression is going to be most important.
Yeah, my grandfather who had glaucoma and cataracts said back in the day, and he said, you know what, Mark, the two things that are most important things you do, well, three things he said. One is when you walk in the room, introduce yourself. Two, show the patient that you're washing your hands or cleaning your hands. And three, make sure your fly is always zipped up. So I'm usually 2 out of 3 on most of those when I walk into a lane. But yeah, it's like think about that every single time. It's crazy. So, well, let me ask you a scenario here. How do you handle the patient that just doesn't want to stop talking? You see, I know you see a ton of patients and they're backed up and your texts are like, "Hey, come on, we need the room." How do you handle a patient where they just want to keep talking?
Yeah, and we all have that patient, and so it's important to use your nonverbals as well because you're not using your verbals because you're listening the whole time because oftentimes your patients, they're still talking, and so essentially go ask him, hey, thank you. I believe we answer all your questions. What I'm going to do is I'm going to hand you over to my assistant, my scribe. They're going to go over everything else with you, and I slowly back away. And then after I walk out there, but I have one more question. And he said, okay, well, I'm going to have my team take care of that. If you need me, I'm looking forward to seeing you at the next visit.
I love that. I do the exact same thing. Usually, what I'll do is I'll say, "Let me get somebody to either walk you up, or maybe they can answer that question for you." I think that's always good.
And then, I mean, we know who those patients are, right? Because we get to know them oftentimes. And so our team, they kind of have an idea as well. And so they know, hey, in 8, 10 minutes, 15 minutes, whatever it is, to help make sure we keep us efficient. Because yes, we'd love to spend all the time with every single patient. And if it's a serious issue going on, we're going to take that time. But if it's just talking and talking, I mean, that's something that we can't do.
You do a lot of work with other modalities, other, clinicians outside of optometry. Um, and do you find, communicating with other clinicians as important as your patients, sending letters, follow-ups, telephone calls?
Yeah, and so working in a collaborative practice or referral center, what we always stress is successful collaboration is all comes down to communication between the patient because the patient has to know what their condition is with the referring doctor, whether it's the surgeon, whether it's the primary care, what were our findings, but making sure we're all on the same page. Because if not, the patient's the one who's going to suffer in the end. And so sending notes, sending secure text. I know we're so used to texting our moms and whoever else we need to text. And but if you're going to send one to to a patient or another provider, it has to be HIPAA compliant, just like emails or whatever. But doing it on the behalf of the patient, being consistent with it, that only helps our patients.
Yeah. I mean, I think things like, diabetics, patients you're following for, chloroquine, any sort of rheumatology patient follow up. I mean, I also think it's important for OD to OD referrals, to make sure you let them know. And I think the biggest communication too is that if oftentimes the doctor who refers a patient in, or the patient has a perception of something they think they should be doing, and you change that, or you realize that that's not in their best interest. I think, it's important to let that other doctor, clinician, whoever it is, know what your clinical basis was for that. And we've had a lot of patients who were referred in for, let's say, like a tetanus lens, who have like RK. And for those of you who don't know, that's a recipe for a disaster. And it's just explaining to them and then letting their optometrist know why we went that route. I think that communication has to go everywhere. So I wanna ask you just to share with me any anecdote, anything fun that's happened in your lane that's just made you go, what? Or anything crazy. I know I'm putting you on the spot.
You're definitely putting me on the spot, but we all have those patients that we see on a daily basis that you just see their name and you're gonna have a great day. You're gonna have a great interaction with them, and you're looking forward to seeing those patients and catching up. That's a one thing. I've been at this practice for about 17 years now, getting to know the patients over time, and I think that's one of the best parts of being an optometrist is growing with your patients and having those. And so that wasn't a specific example, but I mean that's just one of the things that I look forward to on a daily basis.
Communication, it's important. Walt, I appreciate you sharing some pearls and just being who you are. And for those listeners out there, tune in next month for another pod with Collaborative Corner. Thanks for listening. Thanks for your time, Walt.
Hey, thank you.